Huh?
Yeah, fine, sir. I used to visit Ruby Hall with Yash Lokanwala during my fellowship.
Yeah, I remember your face.
You remember me? Yeah. Thank you, sir. Thank you.
So, Dr. Jabir and Dr. Srinivas, we've been together for a long time now. So you are specially invited today.
Thank you, sir.
Maybe more stage for you.
Thank you.
Shall we start, sir? It's 8 o'clock. We are on live.
Yes.
Please share the slides.
Yeah.
We can start.
Good evening to one and all present here. I'm Dr. Neha Jain, and I once again welcome you back to this wonderful evening today. We are very proud to share that today, No Thrombosis is witnessing its 30th episode. What started as a mere idea and a concept has evolved today into the most engaging scientific program of the country. We are very fortunate to have been supported in this endeavor by our mentors, and we owe this success to them. I now take the opportunity to briefly introduce our expert faculty members for today evening. I first introduce and welcome Dr. Shirish M.S. Hiremat sir, who is our course director for the program. Sir is the director at Cath Lab Ruby Hall, Pune, India. Sir was the president of CSI in 2017 and also the program chair of CSI conference in 2016. Sir is also the convener of National Intervention Council of India, CSI, for the year 2004 to 2006. Sir has given many live angioplasty courses to many national and global intervention conferences, and he holds a great experience in peripheral angioplasty procedure, including the legs, carotids, and iliacs. Sir has also participated in some groundbreaking trials. I now welcome our moderators. Our first moderator for today's program is Dr. Jabir Abdullah Kuti. Dr. Jabir is the Senior Consultant and Director of Clinical Research at Lisi Hospital, Cochin. Sir brings with himself over 2 decades of experience in cardiology. He is an expert in managing complex heart diseases, and his area of interest is coronary interventions in heart failure. I now welcome our second moderator, Dr. A. Srinivas Kumar sir. Dr. Srinivas Kumar is the Director of Cardiology and Clinical Research at Apollo Hospitals, India, and Professor of Medicine at Apollo IMSR, Jubilee Hills, Hyderabad. Sir is the Chairman of Facts Foundation, FPS, and also the Founder Director of TCT India South Asia Conference. Sir holds special interest in TAVI intracoronary imaging, and he has also been the past president of APCSI chapter. I now introduce our guest moderator for today's evening. Today we have Dr. Professor Guru Prasad Sogunuru with us. Dr. Guru Prasad is a cardiologist and cardiac electrophysiologist at Shri Guru Heart Clinic in Chennai and progressed Sir is a member of Indian Medical Association, Hope Asia Network, and an Indian Society of Cardiology. Sir has published over 30 articles in reputed international and national journals, and he has also participated in many important clinical trials as the principal investigator. I now introduce our key speakers for today's evening. Our first speaker is Dr. Professor Digvijay Sharma. Dr. Digvijay Sharma is a senior consultant at Fortis Hospital, Delhi. Sir brings with himself over 20 years of experience in vascular intervention and surgery. He holds keen interest in carotid surgeries and interventions, advanced aortic interventions, limb salvage, and prevention of amputation procedures, and varicose vein clinics. And he also manages special clinics like varicose vein clinic and dialysis access clinic. Today, he'll be presenting an interesting case on pharmacomechanical indigo thrombectomy of IVC stenting for an acute DVT in a young man. I now introduce our second case presenter, Dr. Anupam Jaina. Dr. Jaina is an intervention cardiologist and electrophysiologist at Bhubaneswar, Odisha. He's also received training in cardio electrophysiology at the world-renowned Korea University Medical Center. He's the first in Odisha state to do a retrofit PCI of chronic total occlusion of coronary arteries. He's an expert in managing heart rhythm disorders and doing catheter ablation of cardiac arrhythmias. He'll be presenting an interesting case on PCI and calcified coronaries. With this brief introduction, I once again welcome you all and I thank you all for being with us today evening. And I would now request our course director, Dr. Hiramad sir, to give us a brief overview of the program.
Yeah, thank you. We move on to the work. So I request Dr. Digvijay Sharma to give his case presentation.
Thank you, sir.
Dr. Digvijay, over to you.
Thank you, sir. Am I audible to all of us?
Yes.
Yes, you are audible.
So I'm Digvijay, and I head the Department of Vascular Interventions and Surgery in Fortis Groups, predominantly Escorts Okla and Shalimar Bagh. We are a dedicated unit of vascular interventions and surgery, and we run a separate department in this group of hospitals. Now, the case I'm going to present is a 42-year-old male. He has got acute and extensive right leg DVT. By acute, it is less than 2 weeks old. By extensive, in our department, we always mean a ileo above the inguinal ligament extent. If it is below the inguinal ligament, we avoid the term extensive. And it is a right leg deep venous thrombosis, unprovoked. We have a reasonable protocol for DVT in our hospital in young patients. We like to remove the thrombus if it is less than 2 weeks old. We like to remove it completely as much as possible. We have been using needle-based pharmacomechanical methods for the last 3 years or so when they become more common and available in all the hospitals. Before that, we were also okay with semi-hybrid, where we make a small nick in the popliteal vein and another one in the groin and pass a pteromo guide wire from below. And then along the valves, we would actually thrombectomy it with a Fogarty catheter and irrigation. We like to lace it if it is extensive. By lace, we means we will put in a thrombus infusion catheter. The most commonly available in our hospital is a Craig McNamara from Medtronics. Side hose with a valve in the end so that we can lace all along the length of the clot. Our usual dose is about 50 milligrams of Acrylize in about 30 minutes. Then this is done through a posterior tibial vein access at the ankle from a micropuncture needle. Then we put the person prone usually and take a popliteal access so that the indigo cat can go through. It's a 8 French catheter, usually takes a 9 or 10 French sheath to really get it through. And then we usually like to have a separator so that we can plate the thrombus properly. We try to avoid IVC filter most of the time, and we attempt for a class 3 lysis, which we achieve in more than 80% of the cases if it is acute. Then we did a completion angio, and we got a total CTO of the right iliac vein, which was angioplastied and stented. We achieved an unrestricted flow to the IVC. We usually do not adjunct with an AVF unless the lower limb vessels or veins are very poor quality and the inflow is very poor. We do not give an adjunct AVF in this condition. We could discharge the patients on POD3, which is the usual timing for us if we can get hold of it in time. And then we put him on a NOAX for about 3 months. For this one, it was a Rivaroxaban. So this is how we would take an access onto the posterior tibial vein, and then we would put in a 5 French sheath and put in a McNamara to thrombose it. If you can see the right picture, you can see the thrombus infusion catheter actually inside the thrombus, and we do the lacing. I will repeat, if you have a dedicated thrombus infusion catheter, the tip will have a valve so that all of your fluid does not flow at the end. It will come out from the sides and really lace the thrombus and make it soft so that the indigo catheter can suck it. And generally, we don't need more than 2 passes now if you have done a good lacing before you start sucking the thrombus out. This is what we harvested. And I really like to see a functioning valve once we take an angiogram from these specialized catheters, which are very soft. They are so so less traumatic to the veins as vis-a-vis the Fogarty catheters we used to use, and those non-dedicated huge sheets where we just put in a sucker and try to pull out. I don't think we could get such valves if we were using the older technologies. So this picture comes after the first pass because there was a stenosis at the iliac vein. I could see some more thrombus there. I had to put in a second pass. And what we note is collateralization, which tells you that this is a prone position, so his right one will come to the left side. And what we see is collateralization. That tells you that the iliac vein stenosis was chronic and he had time to develop collaterals. And this is the final unrestricted flow to the IVC. You will note that there is a stent on the left side, which has migrated a bit. This was the stent I had put 4 years back for his left iliac vein May-Turner stenosis, and it also presented as a DVT at that time too. So I wouldn't call it a really unprovoked one, but yes, this is how we went, and patient was discharged 3 days of admission. Now, key points is we have got reasonable protocols for DVT and we follow some reporting standards. So if my resident or my colleague tells me we have got an extensive acute DVT, I know it is less than 2 weeks old, I know it is above the inguinal ligament, I know we got to do something about it. So generally, if it is above the inguinal ligament, we want to remove the thrombus all of the time if it is less than 2 weeks old. If it is below the inguinal ligament, then we give a choice to the person of only catheter-directed thrombolysis or only anticoagulation and so on and so forth. And if it is below the popliteal vein, we generally would not intervene. We have reasonable volumes. We are coming up to about 4 to 6 per month now. In that acute phase where we can go in and take the thrombus out, the whole idea being to give a good quality of life in a younger person with minimal post-thrombotic syndromes and hopefully minimal thrombolysis and minimal anticoagulation for a long time. As we keep doing work, slowly we have got a better referral base and somehow we get more patients referred to us. And we have got a very strict reporting standard. So we follow the Society of Vascular Surgery standards of reporting all the time. So that is how we would do a acute extensive thrombo DVT of any leg in a young person. We would like to remove it. We would usually avoid a filter, and if we need to put in a filter, which would only put if the clot was already into the IVC, then I generally like to remove it as soon as possible, if okay, even in the same admission. Thank you very much. Now I'm open to questions on an thrombotic event, venous in the leg for any patient.
Thank you, Dr. Digvijay. I think we are all into a new style. I mean, for me, this is new. I mean, we've been using local thrombolytics into a clot, but we used to make holes ourselves and then...
Yes, those were the days.
Yes. And for a long time, we haven't done anything like this, you know. So congratulations and thank you for opening up a new dimension for thrombus treatment. Dr. Jabir, you have any comments? Dr. Srinivas? Or let's ask Dr. Guru. I mean, you're our guest. You're our guest today. So,
thank you, sir. Thank you. So, just a couple of things to initiate the discussion. It's first of all a very good case. I should really appreciate Digvijay sir for an excellent case and intervening early. Just a couple of things, because as a clinicians and basically physicians, in this patient, 42-year-old male, before we intervene into thrombolysis, thrombectomy or filters, so how are the hemodynamics in this patient? So because especially as per the guidelines, so these aggressive interventions may be lytic therapy or thrombectomies or maybe prophylactic filters, whatever. So we have specific indications which are evidence-based. So how about the hemodynamics in this patient? Was he symptomatic or asymptomatic? Will your approach differ whether patient is symptomatic versus asymptomatic? I need your comments, sir.
Okay. This guy had a sudden painful swollen leg near to cerula dolens.
Yes.
In like 6 hours history.
Great.
And so if it is symptomatic, they generally land up in the emergency. And then, yes, the stability is taken care of. And this guy had come on a wheelchair bought by his friends because they knew what DVT was based on his previous experiences. So if they are hemodynamically unstable, yes, we would not intervene. If they're asymptomatic, I will have to do more workup. But if it is a symptomatic, acutely painful right leg where my Doppler will show iliac vein is full of thrombus, then I will just see the IVC. If there is no floating thrombus there, I would straight away take him to the cath lab just on this after taking his blood samples for coagulation profile before I start a heparin or whatever. So if it is acute, we really treat them acutely.
Excellent, sir. Because this is for the sake of audience and so those who want to know. So please note that the treatment will not differ between symptomatic versus asymptomatic proximal DVT.
Yes.
So what we have to assess is hemodynamics. If there is hemodynamic compromise, as Saur said, it is proximal to inguinal ligament, that is almost iliac system. So we have to intervene aggressively and definitely like lysis or thrombectomy, definitely, sir. And what was your strategy post thrombectomy after discharge? So I think, the another point is it provoked DVT or unprovoked? This is very important. Those who wish to know. So provoked DVT or unprovoked.
What is your second?
Yes,
second DVT? I mean, he already had a lesion in the right iliac.
Right iliac,
which has a stent, and now this is the second. So, Dr. Digvijay, even I was very keen on knowing what kind of test you would recommend. Like, this fellow has come with two important DVT episodes. Maybe there is a long gap between these two episodes. But what are the tests that you would like to do for finding out why he's clotting?
Yes, sir. This particular patient was a known May Turner's on the left side because he was prone. Your left and right is it's a mirror image. So he had a DVT on the left leg, which was a diagnosed May Turner's through a CT venogram. That was like 4 years back. Now this particular one also has got a right leg chronic CTO of the right iliac vein. So this is again a variant of the May Turner's where the right iliac artery is pinging on the right iliac vein a bit lower down than what we see on the left side. So yes, this is May Turner's and will come. So how would I diagnose it? If it is unprovoked, I'm very, very aggressive to look for a stenosis, which even if you do a good CT venogram, you will miss about 15% of the time. We prefer IVUS most of the time to really get ourselves through, sir. To rule out a dissection.
What do you see on IVUS actually?
Sir, we can actually see the narrowing and we can measure it more accurately in an IVUS as compared to CT venograms, which can sometimes be misleading. Formal angiogram will miss about 30% of the cases. So if you don't see on a formal angiogram or a CT venogram, before I tell the patient that there is no cause about his thrombus, I would like to put in an IVUS, sir.
So what was your, because prior DVT makes it a high risk case, definitely. Yes. So what was your discharge advice? What type of anticoagulation did you choose?
We had put him on rivaroxaban for 3 months. And then we stopped the rivaroxaban and then did this thrombophilia profile, the standard checkup. And only thing positive he had was homocystinemia. So we have put them on pyridoxine vitamins and under follow-up now.
So what was the D-dimer level, sir?
D-dimers were shooting 1000 plus.
Correct, because that's important for now, especially acute.
So the only highlight I want to tell you is we generally don't stop till we attain class 3 lysis or a severe complication arises because of our thrombolysis. And I will keep highlighting that before you put in the catheter to take the clot out, if you can take those half an hour or 1 hour and lace the thrombus properly, your results will suddenly be much more pleasant as far as angiogram goes.
So, Dr. Vijay, these things are probably we are more into the coronaries rather than into the venous system and more in the arterial system. So, I just want to ask, is it your routine protocol that any patient with a iliac vein thrombosis, you go and intervene? And when you intervene, will you always lyse the patient first and then intervene?
If it is a less than 2 weeks old, yes, I would intervene. Intervene means I would do pharmacomechanical if the patient can afford it. If it is more than 2 weeks old, then I'm a bit cautious. Then maybe I'll just put him on anticoagulation alone.
So it's a pharmacomechanical is the default strategy, isn't it?
If cost and other limitations don't hold me back, yes.
And, how do you select your vascular axis? Because here you selected the tibial vein, isn't it?
Yes, I like to put
popliteal vein puncture.
Yes, I would like to take my initial access on the posterior tibial vein, because then I can have a long segment of thrombus that I can lace out. It's easy to put. And why do I go for a popliteal vein is because when you lace it and you want to put in a catheter, Indigo Cat 8 will not take less than 9 or 10 French sheath. You cannot put it through. So 10 French sheath won't go from below the knee vessels at all. And so we need at least at the popliteal level. And the more distal you are, the more clot you can remove. So, yeah.
So finally, are you aware of, say, suppose because one's patient is high risk and unstable hemodynamics, so simple lytic therapy versus this thrombectomy, I mean, infusion kind. Are you aware of any evidence?
Yes, yes. There are evidences that plain anticoagulation is least, how we say, risky to me and the patient, easy to give, but also has got a high incidence of post-thrombotic syndromes, which various series will report up to 40 to 80%. Then comes systemic thrombolysis. Systemic thrombolysis will have a bleeding. Once we start systemic thrombolysis, you will have to do angiogram every day or twice a day to carry on with your thrombolysis, back to the angiogram to see when you have got the acceptable class 3 lysis, and generally you will again have a very severe bleeding episode in 30 to 40% of the cases. So if I would say the patient is affording, my only choice is, should I do an angiojet or should I do an indigo? Then that's the only decision making that is pending for above the inguinal ligament for less than 2 weeks old. Otherwise, we are very cautious, sir.
Dr. Srinivas, what is your approach, usual approach to these things? Do you go from the contralateral vein and do a thrombolysis? Or what will be your vascular axis?
Yeah, generally popliteal vein, our other colleague, vascular surgeons do it. We also get involved in between the patient is known to us. But by and large, this procedure is done by a vascular surgeon. And some of the vascular surgeons are standard, outstanding, non-operating vascular surgeons, which help cardiologists also to get in and do some cases. And you use clearway catheter, sir, for giving lesional thrombolysis. What is the catheter of your choice?
I prefer the Craig McNamara, which has got a valve at the end.
Okay.
About 10 centimeters of thrombus segment, thrombolysis working element.
Okay. When they were not there, I think as Hirmat sir was telling, you were using various types of balloons and making holes in the balloons.
Holes with a needle and then hope they don't break when you pull it out. It was
Yes, sir.
But even those, I would say that most of the thrombolysis would flow from the end of the catheter rather than the sides, because that was the biggest hole available for the fluid to get out from.
Yeah.
We try to console ourselves, but without a valve.
In COVID times, you have seen much higher cases of DVT?
Generally speaking, in COVID times, ICU was full, and when ICU is full, you usually get more DVTs anyway. So we don't know it's because of COVID or because of...
No, but I think we did see a lot of increased cases of DVT, sir. We saw vein thrombosis in upper limbs, lower limbs, and all sorts of venous thrombosis we did see during
COVID was most of it was venous and rather than arterial thrombosis that we saw, no doubt about it.
Yes.
And we had a sudden spike, so to say, about 20-30% more than we would like to see.
Yes.
Dr. Digvijay, this intervention is the venous intervention for DVT. What is the most striking benefit? Is it prevention of the post-thrombotic syndrome? A striking change in the post-thrombotic syndrome rather than
prevention of
medical therapy
syndrome, sir. Because when we would put them on systemic thrombolysis or we would put them on anticoagulation alone, when you check up the patients after 6 months or so, their ultrasound deep veins look sick. They're thick-walled, their valves are not working well. Here you can see the valves functioning like in 2 hours of your procedure. So I would say the biggest benefit comes in prevention of a post-thrombotic syndrome, and the younger the patient, the more aggressive we have to be here.
And immediately symptomatic benefit is also there, Zabir. The lot of swelling, pain, and significantly comes down now.
By tomorrow morning, he's so happy, he smiles at you and moves his ankle and shows you that it's all done and wants to go home. That's the very satisfying part of acute and aggressive intervention. I agree about half of them won't be able to afford it. But then only thrombolysis, if you give electrolytes for 3 to 4 days, the cost would just be the same anyway.
Sir, I have a question. How does your intervention strategy change when proximal DVT is associated with distal DVT also? Suppose iliac and both tibial vessels also have DVT, yes. Then how does your intervention strategy
Hardly
change?
Ever, because I'm not going to remove the thrombus which is below the knee. It is
so still your access is from the posterior tibial vein, and then
first to lace it, I would like to take a posterior tibial vein because suppose I can't, once you lace it and you want to put in a catheter, that is the time I put him on prone and then take a posterior popliteal vein access. I do not go contralateral and come down because that is going against the valves. That's something we don't want to do.
Just one comment regarding distal DVT. Just for those who, for the audience, usually what the evidence is, the distal DVT interventions should be based on patient specific, and treating physician should decide whether what he needs. But it is worth to note that especially within 2 weeks, 1/3 of distal DVTs they can just extend proximally. So that is one important point. And in this patient, if it is unprovoked recurrent DVT, especially young age, malignancy has to be ruled out.
Yep.
So that is one important point.
Yeah, that is the part of the protocol. The moment he gets admitted, we generally do a whole body MRI for METs that gets us a good comfort level. But here it was a documented stenosis, so I was not very worried. And this malignancy protocol has been done and followed up with, sir.
This gentleman would get anticoagulation, whichever you choose, NOACs or warfarin.
Yes, sir.
For just 3 months or
at
even
least
longer?
3 months, sir. At least 3 months. We generally like to follow it for 6 months, but I would never advise them to stop before 3 months. You have to tell them very clearly that they need not.
No, I was in fact thinking after you did the right one first, whether you should have continued anticoagulation for a long time.
He was on anticoagulation when he thrombosed again.
Means he was taking it for 3-4 years actually.
Yes, sir. We didn't stop him because he had those 2 or 3 thrombophilia parameters that are positive, and I told him till those are reversed, that's specifically the homocysteine part, he should not stop.
We are in the habit of using aspirin also, sir. Do you feel any benefit with aspirin usage along with NOAC?
If my NOAC is on anticoagulation dose, I would not bother with aspirin at all. But if for some reason I have to cut it down, then yes, aspirin would be added.
Okay.
I think we had very important and very unique kind of discussion. We always been talking on coronaries, and it was nice to deviate and get into an area where you see thrombus, which is important, and people really suffer. Like conventional lysis followed by heparin, followed by oral anticoagulation. So many of them have chronic issues with this DVT. And I'm sure once you suck out the thrombus, all these probably will go away. I'm sure, Professor Digvijay, your patient knew that you got him all right on the other side, other leg, and that's why he was probably very happy coming back to you and get this leg also corrected completely.
That's correct, sir.
Many of these would live with chronic pedal edema, walk limitation, and so on. So I think this is a very important therapy. Not many interventionists are probably getting into this, but I'm sure clearly open area where I think many more should take interest in sort of technique.
Sir, a lot of radiologists and some of them are doing this ablative therapy for varicose veins left and right. If a patient goes to them with the veins, then they do whatnot, laser therapy and all that. What are your comments, Professor Sab, on that?
That's for me, sir?
Yeah.
Okay. I've got what my mentor used to tell me, that when a thing does not have an absolute contraindication, like an IVC filter, like your say stem cell therapy, then it will be done by every, in his words, Tom, Dick and Harry. So that gives you a fertile ground to manage complications, and you should upscale your skills to manage the complications now, because we cannot stop it. But the key rule is, sir, the indication for any procedure is not my ability to do it. It is, can it benefit the patient if done well? So behind every lesion is an unforgiving organ, and they will not forgive you later on.
I think the other point I would like to add, when you do a procedure, it shouldn't hurt the patient in any way.
Exactly.
So there should be no downsides when you have yes, no kind of situation.
Absolute indications you should jump in. Other times you need a good counseling to yourself first and then to the patient, sir.
Yourself first, I think that is a very important part.
That's the key thing. And the key point that I would really like to make is, you see, there are so like point is, sir, how to interventions is an easy thing. It's the 5 golden rules. Have I made a correct diagnosis? Is the pathology reversible? Can it be technically possible? Can I, means my team, my hospital, my resources do it? And very, very important, will the patient benefit from a successful procedure? All of them, yes, then only jump, otherwise we can wait, sir.
I think the last question is very important, whether patient will benefit. And then if you and your hospital cannot do it, I'm sure you can find another hospital or another Dr. Digvijay who can do it for you. So I think the correct referral also becomes a very important issue. And I'm sure many of us learned a huge indication today where therapy would be very effective and would lead to no long-term problems of DVT. And of course, prevention of PE also is very important under these. And Dr. Digvijay, thank you indeed for opening up a new door for many interventionists who are watching you.
Thank you, sir.
Okay, we move to Dr. Anupam Jaina, who is presenting the next case. Dr. Digvijay, I hope you are going to be with us throughout this evening. Okay. Thank you.
Please stay back, sir. We can have some discussion again at the end.
Thank you, sir. So let me just share my slides. I hope my slides are visible.
Yes.
So that excellent case. I mean, honestly, I saw it for the first time. Then my presentation will be about PCI in lesions with high calcium content. As we know that calcium offers unique challenges. And in this case, the patient also offered unique challenges. He was a 65-year-old male. He presented with basically a suprasellar tumor with loss of vision, and his body weight was around 130 kg with BMI more than 40, severe obstructive sleep apnea with home BiPAP. He had LV dysfunction, type 2 diabetes or insulin, hypothyroidism, hypertension. So this was his large brain tumor, 4 centimeter into 3 centimeter. On pre-op evaluation, he was found to have LV dysfunction. Patient did not give history of angina, but definitely there was shortness of breath. So maybe patient was having angina equivalent. And as we see from here that this tram track appearance, railroad appearance with extensive calcification of the right coronary artery. More challenging on the RAO view, what we find is that in the mid part of the RCA, there was a 180-degree bend with very heavy calcium. So that was one of the unique challenges in this case, because as per the standard protocol, in these cases, we need a rota, because apart from rota, it is nearly impossible to advance hardware through these type of lesion. So this 180-degree U-turn was a big challenge for this case. Similarly, on the left side, there was extensive calcification of LAD. So in the epicranial view, the LAD appears to have 99% stenosis with a small channel. Probably, I was thinking that a small channel is visible here. Because of the complexity of the coronary anatomy and the lesion characteristics, surgery was advised, but honestly, no cardiac surgeon was willing to touch him in view of his large brain tumor and so many comorbidities, especially morbid obesity and severe OSA. So we took up the patient after proper counseling and proper discussion with the family, with a heart team discussion. We took him up for a high-risk PCI. So this is an AL2 guiding catheter. And as we see that the mid part of the RCA was the most critical part. However, there's extensive calcification and disease starts from after the ostium. Even navigating a wire through the RCA stenosis was very difficult. So this is a Filter XTR. And because Filter XTR is a very floppy with a hydrophilic property, and every wire was getting stuck in this calcium. So Filter XTR we could navigate. And normally our practice is to take the microcatheter and exchange the rota wire over the microcatheter. So in this case, we selected a Corsair because Corsair has this unique hydrophilic sliding property. It will with some maneuvering, it could be passed across the critical part. Then even doing rota in this lesion was not without problem, because there is any impatience or any forced maneuver, the rota bar would easily get stuck in this lesion. It will go in and then get stuck. So we decided to use a 1.5 bar actually. A 1.25 bar has a very high risk of getting stuck. So we used a 1.5 bar. We gave multiple runs. I think we needed some 3 minutes of total burring was done for around 3 minutes in this case. And after that, we could pass the rota bar and did some polishing run. So that was smoothly, it was going. After that, there was some lumen was gained and some amount of calcium was polished in this case. Next, we took one NC balloon because our next plan was to take the IVL. So before IVL, actually, we wanted to see that if the NC balloon, because of this bend, there is a risk that IVL might get rupture. So we took an NC balloon, 3 mm NC balloon, and tried to inflate the balloon. And after that, we took IVL. So in the second picture, we see that the IVL actually worked and opened up some of the tightest parts. After that, we took the OPNC balloon and inflated at high pressure up to 35, and we could get a good pre-dilatation. Then we took another NC balloon 3.5, and finally we could manage to implant a stent 3.5 into 48 stent. And high pressure post dilatation was done with 4 NC balloon, and also we used OPN to properly post dilate the stent. We could not do any pre-IVUS because the lesion was very critical. So we could not do pre-IVUS. And this is the angiography after RCA stenting. And then we did some did IVUS, and this is the most critical part. I'm just showing in the most tightest portion. And some of the pictures here that we got a good MSA after RCA stenting. It took almost 2 hours, 2.5 hours to complete the RCA. Then we moved to the LAD, and LAD again was diffusely diseased, critical stenosis. So I tried with a pilot 200 because I was hopeful that there is a small channel and maybe it would be possible with a pilot to navigate that channel. But however, pilot was getting stuck. Also, I had a feeling that maybe we are entering into the subintima. But little maneuvering, the pilot could cross, and we changed to Corsair. Then after that, we did LAD rota. So, and because another thing I found out that because the rota bar was probably a little fatigued by repeated rota on the right side, so the rota bar got stuck here. So that another problem. But I was lucky, and the patient was also lucky that a constant firm pressure on the whole system could disengage the rota bar. I do not have picture of that. However, post rota, there was no improvement in flow. So again, we did some good amount of pre-dilatation. We did IVL, and then post IVL we could gain some lumen, and this is a stent was implanted in 48 in the LAD, and this is the final result. However, by that time it was almost a 4-hour procedure, so I did not do any post IVUS in the LAD, only angiographic result. And 1 month after the stenting, patient could undergo, we could stop the antiplatelet, and patient underwent the neurosurgery successfully. So this is the final result on the LAD side. Diffusely diseased, however, we could open up the most critical part. So to conclude, lesions with high calcium content offer unique challenges, and in this case, it was extensive calcification, but we could manage to have some reasonable result. Thank you, sir.
Thank you, Dr. Anupam. I liked your word, rota was fatigued. I thought we use this word only for us, like I'm tired, I'm fatigued, thing like that. But anyway, a case very well done. What about both these right and left to be done together? I mean, I would have probably felt that after 2.5, 3 hour RCA procedure, with extensive rota, I think we clearly distally emboli. And to do LAD in such a sick patient, probably, I mean, you did it, but I would have probably staged it. You know, I mean, I did right first, give a little breather, and then come back to the left. So, Dr. Jabir, what would you do? Both together?
I would, as you rightly pointed out, it is quite prudent to stage this procedure, since a lot of contrast had gone in, and also a long procedure, long time rota. The rota took a longer runs of rota. I think he might have rotated for, I think, maybe half an hour, 30 minutes or so, isn't it? Multiple runs.
RCA was 2.5 hour procedure.
But yes, rota alone might have taken some 30 minutes of rota. But why? I have also done the same thing, like triple vessel rotas. Probably because of only one thing. To cut down the cost, you can use the same birth.
Exactly.
That is the reason. Sure.
Cost
That's
is
the only
the
reason.
So-
Otherwise, any person would prefer to do a stage procedure because
Yes,
the
sir.
operator is not the rota. The operator is also fatigued
fatigue.
after 4.5 hours.
Actually, we had a detailed discussion, but again, I mean, LED, IVL, rota, IVUS, everything, again, double the cost. So,
And I thought you might have had some pulses left in the IVL, but the same IVL cannot be used, isn't it? The LED is smaller. You might have used what was the size of IVL used in the LED? 2.5?
3, sir.
3. And in the RCA?
Same IVL. I used
So the
50
same
pulses.
IVL, some pulses were left. So it is
Yes, sir.
logical, quite logical. He could use the same. Otherwise, 2 IVLs, 2 rota, cost would be enormous.
Very difficult. Yes, sir.
That is one of the
I would have
problems
also
of
felt we could all these percutaneous things for RCA and circumflex, and probably graft the LED through a mini-cut surgery. So I'm talking of a hybrid procedure where
Exactly.
you just pick up the LED and keep the surgical procedure very short.
Anyway, that LED was also not great, sir. Diffusely
Yeah,
diseased,
small
thin vessel. I
diffuse-
don't know how comfortable surgeon would have been to graft that LED. Many times we help our surgical colleagues also where they're not able to
No, I
graft.
mean, if you are going to do angioplasty on any vessel, I'm sure no surgeon is going to say no to grafting that vessel.
No, many times drug-eluting balloon dilatations and all are done on very thin
Yes,
vessels.
sir, yes, sir. So actually, a good thing is that we had a heart team discussion with the cardiac anesthetist, the cardiac surgeon, and myself, and then the
Anupam,
surgeon.
you are the boss. So in this heart team discussion, always one person drives it, and I'm sure you are driving the force.
And one more thing, sir, what we could have slightly done is, as said, the staging is important because otherwise you get
Yes, sir.
fatigued and you may not get the optimal result in the second vessel.
Yes, sir.
Then
Yes,
you
sir.
feel bad for that. And so
No,
it's
no, no,
always better to
fatigue.
stage it.
No, heart will get fatigued, not
Yeah,
you
yeah.
and I.
Yes, sir.
Yeah.
So
And
that's
then,
why you should stage it, not
other thing, probably in such a high-risk patients, again, who are waiting for surgery, we can put a little shorter stent, only focal stenting, rather than putting a long stent, and sometimes it could be challenging to take also. And approach in HBR patients and patients who are waiting for surgery to avoid any problems of thrombosis and further things is we do a focal stenting at that particular focal lesion point. Maybe that would be slightly different, but maybe you felt that the lesion is all diffuse. But luckily, you could manipulate and take 48 mm stent in the RCA. Sometimes it could be challenging again to take longer stents. So try to get out with using focal short stents if possible.
So it was taken by telescoping the
Yeah, I
maxilla.
understand. You must have used, I think you showed all the
Maxilla.
techniques of calcium. You initially used NC, then you used IVL, Rota, then IVL, then I think
Actually, this
OPN.
combination of IVL plus, Rota plus IVL, probably I would avoid it. I mean, I would use Rota and then I would probably go to OPN-NC.
Yes.
Because OPN-NC doesn't swell with a pressure of 40, 45, and 50. So I think that is my combination most of the time and not Rota and IVL. I mean, of course, if patient can afford and you're used to it, and you're willing for a very long procedure, like RCA alone costs you about 2.5 hours. And so it's a better strategy, no doubt about that. But if you want to save on costs, you can use Rota and OPN-NC.
Yes, sir. Very good. Excellent point, sir. In this case, actually, I had a fear that probably the whole of the vessel wall is calcified. So if I go into ultra high pressures, I don't know. I mean, I might cut through the calcium and the whole vessel. I was not sure about the integrity of the adventitia also in this case. So I thought that IVL will be a safer option.
Dr. Jaina.
Dr. Neha, it was a fantastic job. What a vessel, if any intervention is on seeing this vessel, he may pray that let the patient go to the surgeon. It's such a tough disease, diffusely diseased LAD, which was totally occluded. And the RCA is also long, tortuous, extensively calcified. It's a hell of a job. And I must agree with you the fact that the ideal approach is always that Rota plus IVL because calcium is heterogeneous. You cannot have a single type of calcification in a vessel. So it's always multiple: deep calcium, superficial calcium, extensive calcium, all around calcium. So circumferential calcium. So we should be prepared for multiple gadgets in severely calcified lesions. That's the best strategy. But I think Dr. Iramath was telling about to save the money, and to make it more cost effective, we could have opted for OPN. This patient could afford, I think. So he had the luxury of using the Rota plus IVL plus the OPN balloon. And he used the extension direct. In one shot I saw you for post dilatation or something, you were using the guide extension.
Yes, sir. Guide
telescope,
extension.
he mentioned stent also he took to telescope.
Stent also I put the telescope with the guidezilla and then.
Only one thing is,
we probably think less of hybrid procedures. I mean, a surgeon doesn't think of cardiologist and cardiologist doesn't think of surgeon. But this was probably a case where LAD could have been done through a mini cuts surgery and RCA the way you did it,
Yes, sir.
That was
Exactly, sir. Only one issue in this case was that the severe obstructive sleep apnea. So the anesthetist did not want to put him on
anesthesia
tube.
problem.
Yeah. So they thought that once the patient goes into tube, he won't come out of tube.
How did they manage the surgery then? He had a general neurosurgery, isn't it?
Yeah,
yes,
absolutely.
I don't know how it was done at a different center. So they probably did a transnasal surgery.
But one thing which is good, sir, I think in calcific lesions, they are little excusing type. Unlike ACS and all that, you do a lot of stuff, inflate balloons, do a lot of things, nothing happens to the patient.
Exactly.
So God is patient and we will be little always lucky in such scenarios. Very, very rare that suddenly some artery gets occluded and things like that. In spite of your best efforts, arteries don't get occluded. That's out. I think... but that is because of calcific nature of the plaque and disease. And even many of the times your worry of whether it will give up and give perforation and all that, we do see it more in more of a softer type of vessels rather than calcific, little excusing type. So God won't create all bad troubles to you at a time. So I think that way you can get away by doing all stuff in the calcific vessel. But final result was quite good. Sir, sir, you're telling this. I am surprised to see sir telling about surgery. But what I'm saying is this mini thoracotomy business, surgeon has to be very skilled, sir. Otherwise, they put a graft, immediately graft anastomosis. If you see, it's again occluded a tight stenosis. So surgeon needs to have very good skill to do a minimal incision and good grafting. Otherwise, the grafts tend to get occluded. Many of the surgeons are comfortable with open methods and comfortable on pump. But otherwise, if you have to do something new, surgeon is comfortable, it is fine. Otherwise, already vessel is very thin. And if you push it for surgery, surgery is also done and the purpose is not solved.
Dr. Guru, you have any comments?
So that's really an excellent case because it went on everything well. Definitely you are a hero. No comments. First. Second is, yes, because I think, all this, it's not like abroad we keep everything on the desk and then straight away do an angiogram and do a PCA. Probably you might have done an angiogram and planned this PCA.
Yes. It was a properly planned.
So in that case, at least we have time to study and assess the calcium of the. See, probably that curve is really scary. That acute bend, C curve kind of thing. What you said. So if it is nodular, see the Rota usually maybe the experts recommend. If it is nodular abluminal calcium, intraluminal growth, definitely Rota has an advantage. But if it is adventitial calcium like this, more towards media and adventitia, maybe, I don't know. So probably after cutting balloons and then IVL would be the first approach, what I think. So probably in that case, you don't need Rota unnecessarily. And because if it is successful, and see, especially after disrupt 1 and 2, disrupt CAD 1 and 2, see, the advantage of IVL is the slow flow, that the dissection rates are really very, very less compared to Rota, especially the Rotaxis and Prepare Calcium trial. Rota is really good. I've used Rota and only in workshops I've used IVL, but not as a primary operator. But Rota, as a primary operator, I did half a dozen cases.
I think we should.
Rota is really good, especially for nodular calcium, and really, localized nodular calcium. Really, Rota is really advantageous. But the problem is dissection and debris embolization, slow flow perforations, and you need little experience also to use Rota ablation. So definitely, this is good case. You went on well. Let's say perfect. At the end, it is peaceful story. But
So
only thing is,
we should make it a point that we do a plain balloon dilatation right in the beginning with a very small balloon, maybe 1.5 or 2.0 balloon. Then image it from inside and see how much is the calcium along the lumen, because that is very easily accessible to the Rota. And deeper calcium is meant for IVL or high pressure insulin. So I would probably feel imaging and then making a choice on your therapy process is probably very crucial.
Yeah, one of the algorithms, I think the D. Maria algorithm published in JACC Intervention in 2019, it's a very practical guide to decide about the strategy in calcium. So,
can you tell us in brief so that all of us can understand? There are lots of words.
I'll just show that, sir. So
basically, Guru, as you said, it is not easy to take IVL balloon straight away. Even the microcatheter was going with a lot of difficulty. That's where I think occlusive calcium, where the wires also are difficult to go, that's where I think first Rota will help to take a small balloon.
I would feel that either take Rota or cutting balloon. Cutting balloon also very difficult to go.
So, I mean, this is one of the very practical algorithms that in lesions with high calcium, whether it is crossable by balloon or not. If it is not crossable, then second option is, of course, a rotational atherectomy. If even the wire cannot cross, then probably laser will help. And in where we can pass a balloon, then we should try to see the imaging and then decide based on the presence of calcium arc, calcium length, or calcium thickness. So in this case, what happened is the idea for doing a Rota was because it was not possible to advance any hardware through this. So Rota basically gave a small certain amount of lumen to further advance other hardware. So I find this algorithm to be very useful, especially in high calcium content.
Yes, sir, especially as a primary operator. So you will know how you were, what is the difficulty that you were facing.
Yes, yes.
So
I mean,
maybe assessment of calcium, and while accessing the lumen, while passing the hardware, these two will determine which strategy is good. Definitely, I agree. Which strategy is good as an operator, on site. Yes,
and Dr. Ramath, if you look into that algorithm, they have stressed upon your point. You always used to tell, after any calcium modification, you put in a balloon and dilate. If the balloon is not expanding properly, that means your stent is not going to expand properly. Then you have to tackle it again. The deep calcium has to be tackled. Maybe OPN balloon, maybe another non-compliant balloon at high pressure, or even a IVL, or for that matter, excimer or orbital atherectomy if it's available. So the most important thing is first calcium modification strategy. If it is Rota, then you apply the balloon and see whether the balloon expands properly. If the balloon doesn't expand properly, you have to tackle it again. Dr. Ramath, am I right?
No, I would feel if you have lots of calcium in the vessel wall, Rota and IVL will always work. That is the best strategy you can think of. If you do not want to spend too much on IVL, in that case, Rota with OPN NC would be probably my strategy, because here in OPN, the balloon diameter does not swell. Like if you move from a pressure of say 20 to 40 and even 50, your 3.0 would move to just 3.1. And this is how you would hurt the deep-seated calcium without probably rupturing the vessel. So I would probably use this combination. So cutting balloon and Rota on one side, then IVL and OPN NC, or just NC on the other side. So So you pick up one from each group, and I'm sure you would get a very good result.
And the DiMaria algorithm, they always use this cutting balloon and all, or is balloon crossable lesion where the calcium arc is less than 180 degree and the thickness is less. Where they use the cutting
5
balloon,
millimeter or less.
cutting balloon or scoring balloon, and then a high pressure balloon, and then go for a stent.
But I think, Jabir, a point which you mentioned is very relevant because in latest generation stents, they track and go even with minimal bed preparation. And once you take the stent in and it's expanded, it doesn't expand, then you're stuck. Many of the times you are again doing OPN balloon within the stent and trying to dilate. To avoid all that problems, I think good preparation and seeing that it is expanded well, either by imaging or at least by the appearance. IVL, what he showed also, Anupam showed, was very nicely seen. No, once indentation was there, after that it has gone. So that sort of thing, to make sure that everything is dilated well, is important. Otherwise, we'll end up with the stents inside, and then stent indentation in the stent remains. Whatever you do, many times you face such challenges. The later generation stents do go. Previously, they were not going when such lesions are not prepared well. The latest ones do go. I sometimes feel that even if sometimes NC balloons are difficult to go, but the stents go nowadays.
Yes, sir.
So that is the problem. So be careful about not taking the stent in your hesitation without preparation. If you take the stent in, you land in trouble.
So make it a rule that your balloon should dilate properly. It should expand.
That's what I'm saying. What you mentioned is a very relevant point.
Actually, many times I'm moving away from conventional balloon to NC balloons. And my first balloon is probably an NC balloon, and you go high. So if it is a tight lesion, I would take a 2O NC and go high pressure, and then take another NC balloon. I mean, you would probably avoid too much of hardware if you do it this way.
But only problems are sometimes if a lesion is too tight, NC balloons may not go, and a regular compliant balloon goes in easily.
No, NC balloon, I mean, it's clearly understood that they don't have the best profile. I mean, the conventional semi-compliant balloons, they're extremely sleek and they can cross anything.
You think we'll go to Guru's presentation?
Yes, Dr. Guru, we are waiting for your presentation.
It's just one or two slides, that's all, because I was just informed just now. Maybe I'll try to.
Dr. Anupam, thank you indeed for joining us today with an exciting case. And
thank you, sir. My pleasure, sir.
A lot of thought processes as we go further.
Great case, Anupam. Great case.
Thank you, sir.
With all the various modalities you have demonstrated, or various modalities of calcium modification.
Thank you, sir.
Dr. Anupam used the IVL balloon. I mean, he mentioned it so easily, but when you discuss the cost with the patient or the family, it's a huge issue.
The procedure came more than 8 lakhs.
No, but it is too much costly, sir. I don't think that should be that much costly.
Absolutely.
All the technology.
Absolutely.
2.5, but that is the cost my hospital charge.
Too much costly.
How much do they charge?
Same. Everywhere same.
We won't discuss it here. But clearly, it's as good as a whole angioplastic cost.
Yes, sir. One OPN is same as an angioplastic.
Yeah.
Not OPN, IVL.
IVL. Sorry, IVL.
50,000, 40 or 50,000.
Yeah, IVL. Sorry, sir.
All right, Dr. Guru, we are waiting for your talk.
Yes, sir. Can you see my screen, sir?
No.
We can see Guru.
Slides. We can see your name, though.
Oh. Not the screen?
No.
I think it is his screen. Is it? It's blank.
Oh, 1 second, sir.
Dr. Onkar, can somebody help Dr. Guru?
Yeah, we.
Google Drive box. Because this is from iPad. If I press screen, so it is coming as screen broadcast, Zoom start broadcast.
And we see Mr. Guru written there. Only Guru, rather.
So you can mail us. I'll share the screen if it is okay.
Dr. Guru, with the iPad, if you are talking, you will not be able to beam it. If you're beaming it, you will not be able to show your voice. So shift to some other modality. Let them do it for you.
Oh,
Yes.
so
Who? You had an you had an angio today, which is normal.
you are seeing my screen, sir?
Yes.
Yeah.
Yes, we can see now.
So
Yes, we can see your.
no, sir?
Yes, your screen.
Right, sir. Yeah, this was the patient came for second opinion to me because patient was advised bypass surgery. Patient, in fact, went to a local cardiologist in my hometown. So just because she has some atypical changes in the ECG for routine checkup, during routine checkup, she was advised in an angiogram. And angiogram, almost, this is my angiogram. The earlier angiogram also showed more or less the same thing. So, and the advice was Lima to LAD CABC. The report was there was tight lesion or significant lesion of proximal LAD. So I took I've studied I did study that CD, and then I said it looks borderline to me rather than tight. So I prepared everything if it is required for PCI with imaging. And before I want to intervene, I want to be sure because someone has advised a bypass just because it's a proximal lesion of LAD, osteoproximal lesion. And this is the angiogram, though because I'm unable to show the live, but this is the picture. So, and the arrow mark is the other vessels are normal. So maybe you can see this. And so borderline lesions, yes, definitely there are certain modalities, especially in the era of imaging and physiology. We can study both anatomy and physiology based on the tools now. Anatomy, like, IVUS and OCT, including 3D OCT. And physiology, like we have fractional flow reserve and other derivatives of fractional flow reserve, like IFR. And of course, we have even more sophisticated, even MRI contrast-based perfusion imaging. Recent advancements in cardiac MRI assessing the function, flow reserves of the myocardium. So simply because on-site in the cath lab, what is available is fractional flow reserve, FFR. So this is a simple routine thing. And these are the values I got is, so after hyperemic adenosine test, during hyperemia, after injecting the intracoronary adenosine of, I think, 150 microgram bolus. So this is the titration, and this is the value I got. So 0.91 fractional flow reserve, and I think I also got, so I tested a couple of times. So it was not, it's always more than 0.9. So this is just to highlight the role of utilization of hemodynamic, assessing the coronary physiology. Though we have, IVUS and FFR, especially if we are ready to go ahead for the PCI, to go ahead with PCI, and maybe IVUS, and they're a bit costly for especially cash paying patients. Both imaging modalities are a bit costly compared to FFR. So, and most of the times, at least a couple of times, 2 to 3 times, we can even, after adequate and proper sterilization, we can reuse even FFR catheters. So this is one such, simple modality to highlight the role of studying either coronary anatomy or physiology. more so the physiology, because anatomy may, especially borderline lesion, it may fool us sometimes. And especially having said, false positives and false negatives are usually rare. If we use the proper technique, if we measure during hyperemia adequately, and after adequately standardizing, and if the technique is proper and FFR is very simple, it doesn't need expertise, not much knowledge, and it will really avoid false positives, false negatives, and it is a good assessing tool to take the decision. In fact, I have advised only medical management follow for this patient. This is the simple case I want to share. And
Guru,
I
this
need
adenosine you gave as a bolus, or you give it?
Yes, sir. Yes, sir. Intracoronary bolus. We can intracoronary bolus. Usually 50 to 100 mics for right system, and the left system 100 to 200 microgram bolus, sir. Intracoronary adenosine.
We generally give it as an infusion.
Infusion, yes, sir. Yes, you're right, sir. You're right, sir.
Bolus, you give intracoronary bolus, right? You had a push.
Yes, sir.
We
yes,
give
sir.
it.
Yes, sir.
No, we give it in a big bore intravenous infusion, or about.
Yes, sir.
Set speed.
In fact, I was searching the literature. Yes, sir. It's a operator preference. Both can be done, especially 140 microgram per kg infusion. Intravenous infusion, or
which is better and which is correct. Let's ask Jabir.
Maybe, sir. Maybe you are the expert.
Jabir, you are champion.
We have used both. When the FFR came in, it started with intravenous adenosine, 140 microgram per kilogram body weight for 3 minutes. Some people use it for 2 minutes. We then shifted over to intracoronary adenosine, and now we are back to the intravenous adenosine, which seems to be the standard and the gold standard.
No, why? Why all this change?
Intracoronary adenosine, I think no standardization. Many people say many have different doses. As he said, Dr. Guru said he is using 100 to 200 micrograms. I was using 400 micrograms in the LAD and 200 micrograms in the RCA. No standardization, but this IV is well validated, standardized, and everybody agrees. There is a consensus of opinion by operators across the world that IV may be better, and it is the one which was used in majority of the studies, the FFR studies.
Dr. Srinivas, how do you use?
I think we should make it very clear to everybody, sir. This intracoronary business is a little tricky. We can reproduce any of the FFRs, whatever ways you want, if you're doing intracoronary. So I think the standardized way is intravenous. The standardized way now is continuous IV infusion, which nobody can manipulate or do anything. It will come standard, and you do it in the same way. It always reproduces the same value. The intracoronary stuff is when you're turning the 3 ways while injecting, there's a lot of gaps happen, and the machine senses it wrongly and gives each time different values. So that's a fallacy of the way we are injecting, of course, I would tell it. But initial studies were saying both intracoronary and intravenous are good enough. Hospital owners may not like intravenous because you use a lot of adenosine. But the intracoronary, you just give one ampule, that should be sufficient. But by and large, what should be advocated is intravenous, and as you said, wide bore and as close to heart as possible. In your lab, you said you're doing through femoral vein to give it faster.
You should give
or
it
jugular,
faster.
whatever veins you can give it faster. And then intravenous, I feel, is less dependent on the technique, what you're using it. And you should promote using of intravenous always if possible. And Guru, you're very happy in that patient, I think, because it came negative. When you have difficult lesions to tackle.
Yes, sir, definitely, sir.
No,
Yes,
Dr.
sir, yes,
Guru,
sir,
I would
because
still feel that this patient now, I'm sure he or she is discharged, but you should still get a stress thallium done on her because stress test was positive, your FFR came negative, but we are questioning the way you did FFR. And that's why, if you're in doubt, you should do both. Sometimes we give bolus, and if you're not happy, if it doesn't match your mental thinking,
Yes, sir. Because patient never complained of angina. Never complained of angina. She is able to walk.
Also is important, you're saying.
Yes, sir. And especially I was following the update by Morton Kern. It's a beautiful chapter on the update how to use FFRs. So if the technique is proper, like you said, sir, Srinivas, sir, if the technique is proper, both are good. So that's the update.
No,
yes,
but
definitely.
We are all talking of your technique of using a bolus.
Yes.
I think all of us are using intravenous
infusion. Yes, sir.
And,
I do.
Yes, I think you must see a physiologic response to adenosine.
Yes.
And then at that time, at the peak, if you get a clear low value, it is positive. I feel this lesion needed something. And
because it was looking more tighter, no, sir? We never thought that it will come so less. If it was coming 0.82, 0.83, they would have...
Because this is the frozen image. This is the frozen image.
That too, Dr.
Could not show the light.
It's a proximal or orchial LAD, which is a huge area. And if she gets infarct, unfortunately, it's a big damage. So I would probably do a stress thallium on her and sort of quantify how much is the ischemic burden.
Yes, sir. In fact, I have ordered stress thallium just for her.
On table, if you have to do, sir, sometimes you can take the help of imaging also. Like if you find areas of proximal LAD less than 4, that is generally correlated with significant...
No, but let's sort of go with some kind of understanding whether intracoronary adenosine bolus is better or infusion intravenous is better. I think, Jabir, you have a lot of these plus minus experiences. So what do you think of this?
Intravenous, no doubt, sir. That is the gold standard. It is intravenous, not intracoronary. And it produces a sustained hyperemia. It gives us the sustained hyperemia that is not given by the intracoronary adenosine. It builds up. We can see that it builds up, and it reaches a steady state, which remains there for some time. And that steady state is what we require. That I don't think cannot be reproduced by the intracoronary adenosine.
Yes.
Yes. Jabir, does it happen? Has it happened to you that you feel the lesion is critical, and whichever way you do FFR, it is coming negative?
Yes.
And then what do you do?
If I think the angiographically, if it is quite significant, then mostly we may not do the FFR.
Correct. But if you do it, or if somebody else has done it.
Unfortunately, we do it and it comes as negative, then we are in trouble. I'll take the help of an imaging also. I'll take the help
No, sir. As you said, some in the live case, if you're taking help of FFR, you should believe it. Otherwise, don't do it.
Right, absolutely.
Especially in one of the international workshops, all these doubtfully, after putting a stent, maybe distally you may find another lesion, whether to go ahead with another stent or not. This is in the workshops, but they do FFR. If FFR is negative, they don't intervene.
Yeah, definitely. Sir, but recently, did you hear Bernie Mayer speaking on CSI? He is vehemently against FFR. He said the same FM3 trial, if it was done without FFR, it would have come equal with PCI and CABG. This FFR is a wire which damages plaques, and borderline plaques get disturbed, and patients who are coming FFR negative, leaving, they're suffering events, and they land in trouble. So he was dead against FFR, and other 2 trials he quoted which came negative for FFR, which said,
the flower MI one.
Yeah, flower MI is one thing, which is same, both are not different, he quoted. And one more trial he quoted, he said, is more events happening with FFR. That I think published 700.
And not to use FFR to take the decisions. Yes,
he says, don't use FFR alone. He was totally against it. I was surprised. Bernie Mayer is generally very sensible and tells good points.
But one thing, Dr. Srinivas, this Bernie Mayer is against all new technologies. He says that he doesn't believe in bifurcation stenting. You stent across the side branch, that is all. He never bothers recrossing.
He generally says, tries to simplify things generally. This thing he was very clear saying that FFR, the wire, something is very, listeners also should take it is, FFR wire is not like a routine wire, and it is more stiffer, and it need to be respected, and don't poke around if it's not going easily. Respect it and try to see that you pass the wire without much of resistance. And
And it is useful.
Have you passed the FFR wire through a microcatheter kind of thing? I mean, what you can do is you have that green light at the back end of the wire, so you cannot push it through. But I have seen people disconnect it temporarily, push it through a microcatheter, remove the microcatheter, and reconnect the sort of, what do you call, I don't know.
And then you have to start from zeroing onwards. Once you disconnect, it's from zeroing onwards. You have to connect it, zero it.
That's, I mean, it doesn't take so much time, but I mean,
as a last resort, what sir is telling is sometimes you're not able to pass. You could take the help of microcatheter to pass the wire. But again, there could be some challenges, as you said, for again,
I'm asking you, is it allowed to put a FFR wire through a microcatheter? Because, you know, so many times the lesions are very difficult, and you are going to do FFR only because the lesion is difficult, and you want to be sure that it needs to be done. So I was wondering this, but you can disconnect the back end, put a FFR wire, and reconnect, and then go ahead.
And Dr. Guru, at the same, there is a data which shows that those lesions which were looking significant angiographically, that is very tight lesions angiographically and FFR negative. And if PC was deferred in those cases, the event rate was not high. So event rate was not high when we deferred, and on follow-up, the event rate was not found to be high. So they were.
So what are you? No, Jabir. What are you concluding? What are you concluding from this kind of statement? Lesion. See, as I understand, and for everybody else, the lesion on angiographical is looking critical, and FFR is coming negative. Is it a distal kind of lesion with very little length beyond the lesion? I think that is one area where FFR would come negative. But if it is a proximal vessel and an important lesion, I haven't seen FFR coming in.
But as experts, I put it this way. I mean, should we need to respect anatomy more or physiology more? Simply.
I would say it depends upon the scenario. It depends upon the scenario. If it is acute coronary syndrome, we respect the anatomy more. If it is chronic, like calcific vessels, and where Guru is not wanting to put a stent like that, then probably you can take the help of FFR, and comes negative, you can leave it. But as sir mentioned, you have to make it absolutely sure, where especially in the proximal LAD, osteal LAD type of lesions, if it comes negative, if you land in trouble, the patient would have a large MI. That's why what sir mentioning was you double check it. If you have,
I repeated thrice, sir.
Yeah, that's fine. That's fine. You did.
But unfortunately, every time you gave coronary bolus, why you didn't switch to intravenous surgeons? You know.
Yes, sir. I valid this point. Yes.
I think that is one very clear learning from me from this. Bolus may or may not give you as accurate reading as intravenous infusion.
Yes. There are some cutoffs values just coming, sir, in imaging. Are you aware of it? Any particular this thing? Many times you get a doubt. Left main, now you have a cutoff value of 5.2. If it is less than that area, you take it as important. And osteal LAD, osteal LCX, there are occasional studies which have come up showing that it is less than 4 for osteal LAD or a proximal LAD, and probably less than 3 for osteal or a proximal LCX lesion. Then it becomes important, and you should intervene it. If it is more than that, you can leave it. And usually FFR comes negative if these values are more than that. They're trying to correlate and see in our lab also. Sometimes it really comes like that.
I'm very happy to hear this from you, Dr. Srinivas, because whether to do circumflex ostium, like you do put a stent left main to LAD and you stop, and you do not do anything to the circumflex lesion, which is looking like 70%, and FFR is negative, you would probably leave it. And I'm very happy leaving circumflex ostium as it is. I'm sure many of us would probably agree, because when you do a bifurcation two-stent strategy and patient comes back, most of the time, it is the circumflex stent which has got ISR, and left main LAD stent is flowing beautifully. In that case, some people still believe that don't touch, let the ISR be there, and you tell the patient to go on medical treatment. And they have strong reasons. I've seen some experts saying that, and they have very good reasons for saying that. And I would also probably feel that circumflex ostial lesion, I would not like to stent. If it is isolated left circumflex ostial lesion, what is your strategy, Srinivas?
That's what these two are difficult scenarios. We have not yet conquered osteal LCX. And other thing I'm really worried is sudden slow flows happening in acute MI scenarios. You're at a loss sometimes what to do. And LCX, if it is the smallerish, small size LCX, we tend to avoid. And as you said, try to continue with medical management if RCA is very huge and LCX is small. But if LCX is really big, especially if it happens in left dominant type of scenarios, there I think we have to do something. We can't leave it. So we try to do various types of cutting balloon, do various types of things, and then probably try to position it probably very osteal location of it. But we don't do routinely like a left main to LAD crossover. How we do it for LAD osteal disease? Somehow we don't do it as for LCX, left main to LCX. So we try to place a stent.
Dominant.
Yeah.
Suppose your LCX is dominant vessel. There is an ostial lesion which is coming positive on FFR, and you decide to stent.
Yeah.
So just at LAD ostial, we bring the stent back to left main. What is your general advice? I'm talking not.
That's what, sir. I'm telling that only. We don't do left main to LCX as it recommended in LAD. It is not for LCX.
If it is dominant LCX, then.
Size-wise, if it is maybe too big, same, sometimes we might have done it, but generally it is not recommended because LAD is important vessel. 50% of the supply, as we have to respect the LAD, that sort of thing is not followed. But we try to place the stent exactly after proper LCX osteal lesion preparation by cutting balloon, or try to cut those circular fibers in the LCX by some measures, and then try to place a precise positioning of the stent. And with the coverage, I think you need to again put a wire in LAD too. And many of the times, if there is a mild, moderate type of LAD osteal disease, you end up doing both. But otherwise, if LAD is left main are totally smooth, even by imaging wise, everything is okay, only LCX is involved, we try to do it like that. But still, we are little worried, as you said. And if it is very small, it's better to leave it rather than fiddling around producing trouble to LAD and left main.
So, can I summarize for you and you say yes or no? I mean, LCX ostial lesion we are talking about. If that LCX is non-dominant and RCA is a good dominant vessel, try and be on medical treatment.
Yes.
LCX is big vessel giving lots of supply to the left side, multiple OM branches. And in addition, the RCA is not a dominant vessel. You stent, but when you stent the circumflex ostium, you always like to have metal on either side of the lesion. So many times you may have to bring the stent back to left main. And if you want to really avoid stenting to the LAD, which is not diseased at all, I would probably get enough length of stent in the left main. Dilate the portion in the left main with a bigger diameter balloon, something like 5 millimeters or 4.5 millimeters, but a short balloon necessarily, so that you don't hurt the opening of the LAD or LCX, and then use a separate balloon for the non-compliant balloon for the LCX ostium.
So you mean to say that you are putting some struts across the LAD ostium by this?
Yeah. I mean, that you will have to see. If you have a strut across, I would get the strut out. But that would be a very low pressure inflation on balloon. And the balloon looking towards LAD on a wire going towards LAD should not go deep into LAD. It should be just at the sort of level of the stent. So just a little protrusion towards LAD, and you open the
What are your thoughts, sir? Like nowadays, many times you leave with one strut's protrusion into the vessels. Suppose the LCX ostium and coming at a junction, suppose left main to LED is like this, LCX is it. A few one strut coming into the junction, it will get endothelialized, no? Why? If it is not compromising the flow into the LED, would you leave it?
No, I would get the stent strut out of the main circulation. Like if this is your circular opening of the LCX mouth, and if your stent strut is right in the center, I would get it out. I would push it on the side. But when I'm doing that, I would use two balloons, one towards the LAD and one not deep into circumflex, but just the mouth of the circumflex. So you are not, in fact, touching the intima of the circumflex, and you are just pushing the strut out.
No, what you're telling will happen when the stent is crossing over, no? So strut's coming across the LCX ostium. What I'm talking is LCX ostium and a stent protruding slightly above 1 millimeter like this towards the left main LED junction. Would you accept that?
No, I didn't understand your question.
Because precisely if you have to position the stent in the LCX, obviously one strut has to come out of the ostium of LCX, which will be coming just at the junction of left main to LED, suppose, that point, if it is 90 degrees LCX. So minimal 1 or 2 struts could protrude into the junction. So you are comfortable leaving it, or you want to oppose it again?
Yeah, you are talking about the isolated ostial circumflex.
Sir is asking that only.
You are putting a precise ostial stenting of the circumflex with 1 or 2 struts. It has to. Otherwise, you will miss the ostium.
Miss the ostium. True.
One strut has to project into the left main.
So if it is left, I don't think it should cause a great problem, I feel, rather than again doing all that and damaging LED left main. These are some of my thoughts discussing loud with you people.
No, I generally think like you, and this is how I used to think. But people have spoiled me. I mean, they kept telling me, no, honestly, I mean, a simple circumflex ostial lesion, which you would be happy stretching it to the fullest, getting a perfect results, left main looking good, LED looking good. You do an imaging from left main to LED to left main, and they all look good. So I used to stent like this, but by attending the conferences again and again, I have spoiled myself. So I bring that circumflex stent back into left main, and then start worrying about the LAD. And if there are some struts across the mouth of the LAD, I like to push it on the side.
Then we will do it.
So the flow and future access to LAD. I'm actually talking more about future access. So when 4 years or 5 years go and you need to address the LAD, which was not diseased today, you don't want to do anything to that left main circumflex stent when you're doing another angioplasty to LAD 5 years later. So that access is best preserved if you take out the stent strut outside. So it is only for that reason that I would take it out. Otherwise, many people say some tissue will grow on it and it will not be obstructive. I agree with all this, but I think future access. So young patient, I would always do it. You know?
So your current strategy is no isolated, no precise ostial stenting of circumflex. For that matter, no precise ostial stenting of either LAD. It's always a LM crossover, and then tackle the struts. Yes. Open up the struts with a small.
No, let me add to this. LAD ostial, we used to always bring the stent back to left main. Now, with listening to so many things, if it is a big circulation circumflex or a dominant circumflex, I treat it like LAD, which means bring the stents back to left main. And when you bring it, you need to have at least 6 millimeters or 8 millimeters, because that is the length of the big diameter balloon that you will get. So enough metal is also in left main.
Yeah. That's what you recommend for LAD. If its LCX is bigger, you are planning the same, you're saying, provided you remove the struts from the LAD ostium. I think that's what it bothers us sometimes, sir. But I think what will happen if you just put minimal protrusion of one strut into the LCX ostium and nothing is done, anything else?
No, I think we are all grown beyond that, and we used to do it in early days.
No, you mean to say you're worried about restenosis happening there, or what is the problem?
Yes, absolutely. For circumflex, definitely there is a strong possibility of restenosis.
Okay.
And the restenosis is then going to occupy everything in the distality of the left main. So it will be left main, it will be ostial LAD, and it will be an ostial circumflex.
Yes.
Which is a disaster.
Sir, I think sir is Digvijay Sharma sir has tolerated a lot of our coronary discussion. With your permission, I'll just ask one or two doubts to him, sir.
Yes, sure.
Yeah.
In fact, he's been keeping very quiet. And
yeah, sir, one thing I noticed is people are doing, people are coming with DVT, and then people do laser therapies or things like that in these vein clinics. It looks so horrible. When there's already a problem, they're creating more trouble. So I want you to just...
What looks horrible?
No, when there's already a DVT, people are doing this laser ablation therapies inside, and there's various types of RF energy deliveries techniques have come for varicose veins treatment. They are actually recommended for hugely dilated varicose veins for treatment. Then patients come with DVT, they're just passing that one run and DVT is flaring up. And I've seen such examples happening. One occasional patient after a laser therapy coming with infection, which is that is unfortunate for some patient. Any procedure can have trouble. But in patients who have frank DVTs, what are your thoughts in people doing just those treatment? Nothing else they do, but for running those. I'm talking about so-called vein clinics. So I want you to just comment on this and also tell us what is the absolute indication today. How to treat in this venous disease treatment with those catheters?
For the varicose or the DVT, sir?
For varicose veins and DVTs, do you agree with those just passing off the same treatment of varicosities for DVTs?
Sir, if you have a pre-existing DVT and somebody is doing varicose vein surgery, this is highly questionable. Because if the deep vein system is not...
Can you be a little bit louder, sir?
If your deep venous system is incompetent and you're running after the superficial venous system, that's plain stupid, to put it very mildly.
Yeah. That's what I wanted to hear from you. Because people say, I want to tell a lot of things happen, but I wanted people to know what is right.
So the varicose veins, generally, the absolute indication to do is a competent deep venous system. And the most common indication that I get is the patient says it is looking ugly. Let us be honest about it.
Okay.
Then comes the symptomatic varicose veins that are the so-called medical indications. So varicose veins are, like I said, with a incompetent deep venous system, if you are hitting the varicose veins, you are doing nothing. It doesn't work.
I think that point should be highlighted because wherever if patient goes with the veins, then people are doing those therapies. So obviously that means they're doing 100%.
There's a thing in the military.
No, that could be beautification also, Dr. Srinivas.
They also say that patient is coming to me for the treatment, I will do it.
Sir, it is like this. This is a term in the military that you have a sword, you don't cut your lady fingers with the sword. You need a different... You just... the patient comes to you and you are doing it for him, then you're not a physician. You're running a supermarket.
That's that very nice. You echoed my thoughts, sir. I wanted to hear somebody, specialist, talking because I keep arguing like this. Many of them criticize me.
On-demand surgery.
Oh, new terminology. On-demand procedure.
And there were 2 or 3 things I could relate to Jaina's case. One was his term for rota fatigue. It's very nice to see you doing rotablader for 0.5 centimeter of a lesion and call it long. We are used to 10 centimeters of below-knee arteries and we go through with the rotablader like a bulldozer or something. And most of my rotabladers are fatigued in one go. They don't work anymore. Second, I understand.
How do you realize that it's not working anymore? I mean, how do you come to a conclusion of rota fatigue?
Sir, the moment you want to take it to the other artery, it just won't push through. then you don't push it with your hands. The rota has to do its own job. The most critical mistake is you want to give manual push to it when it should be drilling by its own. It's just a
So if the rota drill is unable to push itself further,
yes, then
that is the time you say it is rota fatigue.
Go with your hand. That's not what just gentle fingers is good. I've seen people use their shoulder muscles too. That's not. And second is preparation of the bed.
No, 1 minute. Since we're talking of this shoulder push, if the lesion is not getting cut, and that's why the rota is not going, what are the hints that you want to give us?
Sir, I would not use more than my finger push. Never. Because
so you would downsize?
Yes. Then I would downsize.
So say from 1.75 you'd come to
our strategy
1.5 or 1.2.
Like we are used to dealing with more than 10 centimeters of CTOs below the knee. We would take the smallest rotablator that we are comfortable with, not the biggest one, and let it make a luminal gain. After that, it is balloons. We just want a luminal gain so that you can get the hardware across. If you want to drill through, the choice is between a atherectomy cutters, where you can actually cut the atherectomy back. They are directional atherectomy systems, but then you need to add a filter. Then things become more complicated. So we have to keep it simple, because in my case, if you have a very bad below knee arterial system with the critical limb ischemia, the person lifespan is about 2 years generally. So we don't do like everything there. We just want to make sure he lives with the limb for the rest of his life.
Or the ulcer heals.
Ulcer heals, exactly, sir. And for that, if it is very difficult to go through, then I would straight away go for a deep venous arterialization and don't even bother, because it's very easy to rupture. When you're drilling through a long CTO, you can really, and you're using shoulder push, the wire will bend and you will make a hole in the artery.
Dr. Srinivas, I think we should also start doing a bit of surgery, So,
we were getting inspired by you and you are taking us retrograde now. We should do it. I always felt that should be balanced, and really heart team should function like heart team. It's not that only one person, the patient goes to a center where surgeon dominates, surgery dominates. Otherwise, patient comes to Hiramat sir, intervention now. It should not be like that. Basically, we should have our, in today's era where I think a patient goes for CABG, when I asked you, I think sometime, if patient has 2 or more CTOs, I think there's too much to do only by PCI. And if patient has good graftable vessels, that is again good indication. Just because CTO, if everything is diffused disease, again surgeon also won't be willing to take up such cases. And patient with left main bifurcation with severe triple vessel disease, again, that is another indication. And patient coming with restenotic lesions. After you tackle it once, it is okay, but second layer of stent, the third layer, you should not. And then that point where I think you should still think of surgery. And then fourth indication for surgery in today's is basically patient has associated valvular heart disease, which again can be tackled by a surgery at the same sitting. But though some patients who are wanting TAVR are not wanting it, especially once a bioprosthetic valve, aortic valve degenerated, he had a left main bifurcation. I told him to go for left main by CABG plus repeat surgery. He says, my horrible experience of first bioprosthetic valve, aortic valve, I don't want to go for surgery. He forced me to put a left main bifurcation stent along with TAVR. So these are 3-4 indications where even today's era, I think we should still consider surgery.
Yep. And so there's a very strong saying for the aortic surgeries. It is hardly ever the patient who is unfit, it is the surgeon who is unfit for the procedure. So, but
Digvijay sir, we are coming over that barricade now. I am not bothered whether the patient is high risk, low risk, or moderate risk for surgery, because those days are gone where TAVR was being done only for patients who are high risk or moderate risk. Now even low risk, actually it is almost becoming like a stenting, coronary vasculature now, where patient is fit for stenting and all revascularization can be done. You do percutaneously. Obviously, it is less risky, less invasive, and less comfortable, more comfortable to patient. Same thing with the TAVR. I send for surgical AVR in a young patient, agreed, because as for age is more than 65, and if patient has no contraindication for TAVR, TAVR can be done. But if he has a low coronary access, patient has hugely dilated aorta where something else needs to be done, those are the cases. If their patient is not suitable for TAVR, then he goes for surgical aortic valve replacement. I think we are gradually reaching there. So with low risk trial showing very strong data coming up, showing that we have less of strokes and less of many problems. We have 12 parameters taken, out of which only 2 parameters we are lagging behind surgery. One is a complete heart block. Second is paravalvular leak. Paravalvular leak, I think we are tided over now with good cuffs, modification of valves are coming in. That problem is not there. Now we have to only address the problem of pacemaker insertions. Now with the study of membranous septum coming up and positioning the valves in the cuspal overlap technique, we are almost there. The same rates like pacemaker rates like surgery. So I'm not bothered whether patient is high risk or low risk for surgery. So as you said, one of our surgeons is very competent. There's nothing like high risk for him. Even the sickest patient, he will operate. So that is also not good. So what is correct for the patient, we should keep doing. I think we are nearing time, sir. Thank you.
What about, Dr. Srinivas, what about younger patient? I mean, you did say these are bioprosthetic valves,
Yes.
So they are not going to go for 25 years.
That's why I said more than 65. More than 65 years of age. In West, they are taking more than 70. In India, probably we can take more than... I never advocate TAVR in less than 65 years of age because data now is up to 10 to 12 years. So if patient is more than 65 years of age, then only I'm talking. If it is younger, even if some patients push me to do TAVR, a 55-year-old gentleman comes and pushes me to do TAVR, we are resisting it. Though some centers, they are doing it. But their argument is Edwards valve, which is almost like a surgical valve. I want to put it. Later on, it is like same like surgery, they are arguing with me, saying that in younger patients also people are doing. But as of now, I feel patients who are elderly, age is a very strong criteria to say. As you position yourself, you decide for PCI, then postpone surgery, midpoint of a lifetime, you do CABG, later again, you could do PCI. That's what you mentioned in the last time in the coronary discussion. Same connotation I apply for TAVR. So you should plan it well, whether you can do TAVR, SAVR, TAVR, or SAVR, TAVR, TAVR. So like that, we should plan our procedures well. And if patient is 65 years plus, then only consider TAVR immediately, unless patient is too high risk where severe erectile dysfunction, 20% EF, surgeon is not wanting to touch CKD, other problems, then you might be considering it as a life-saving procedure, but not as elective procedure in younger patients. And we have not reached it there, but probably if you have better valves lasting for more than 20 years in future, we might consider it for younger patients also. As of now, 65 years patient, if patient is suitable for TAVR, we can do TAVR. And if it's not suitable for TAVR, then only he'll go for surgical aortic valve replacement. Those days are gradually coming.
And Dr. Srinivas, I think
the age, Dr. Srinivas, age. I mean, I'm very perplexed. Like
yes.
People used to say, do angioplasty first, get them to an age of about 75, 80, and then think of a bypass surgery. That one bypass will take them to beyond 90. And I still very strongly feel that once you do surgery at age 50, I think you have ruined his future.
Yes, very correct.
You're talking of just about 20 years from future. So I would probably always feel that angioplasty first. And if your patient is beyond angioplasty, then surgery.
Yes, agreed.
I'm not trying to say surgery is a bad option, but if you see the spectrum, like say 55, then you want to take him to 85. Many people want to go to 85. Many people want to leave the country at age 85 and 80. So I would probably feel that if you want to keep them moving, you would need 2 procedures from 55 to 85 or 90. And which one first? I would always choose angioplasty first.
If a patient is coming at 65 years of age, sir, suppose, hypothetically.
Yes.
Then if a patient has a left main trifurcation disorder, the medications what I mentioned, probably you can send for surgery. If a patient is before retirement, before active life.
If it is just a left main bifurcation, I don't think we should send for surgery.
That's what, sir, I'm saying. If it is young patient, you would avoid surgery. 45 years, 50 years, If you can do revascularization, total revascularization by any means, you do percutaneous procedure. But the patient is elderly, like coming at 65 years of age. What are your thoughts?
65, I don't think many people think it's an old age anymore.
So you do PCI at 65?
100%.
So when do you do send the patient for surgery?
Surgery is about 75.
No, 75 surgery is high risk surgery, sir. I don't agree for sending. I will say that 75 elderly patient, high risk for surgery, better not send for surgery, do at least a palliative PCI. What are your thoughts on that? Surgeons are not comfortable. Many surgeons are not comfortable operating on a 75-year-old gentleman.
No, this is a very wrong concept. I mean, if they don't want to operate at 70 and 75, they should stop operating. I mean, clearly the life has changed for you and I.
Yes, agreed.
Yes. And we didn't think it like this earlier. 20 years back, we used to say 60 and above, I think maybe surgery could be a superior option. But the way angioplasty has progressed, the way angioplasty has given brilliant results, I think we are pushing surgery. And for some people, I've done one gentleman, I've done 3 angioplasties at different ages, and he went to beyond 95, and he never needed a bypass surgery.
Yes.
So how things will change and how stents will move. I mean, of course, I'm not trying to say the surgeons are not moving. They're also into very fancy grafting, which can go 30 years and 40 years. So I would also probably feel that, I mean, even the surgical valves they put in, they're great. I would probably feel longevity when we are talking about the valves become a very important issue because they're all getting operated at 30s and all.
Yes.
The valve must go another 30, 40 years. That is the real beauty of a good valve.
So in your idea, probably you are sending such surgery only at 75?
Yeah, I mean, I always like to think if I can do an angioplasty, patient is 75 or less.
Oh, okay. So but I don't think at 75 also patient requests you to do PCI, you would still do PCI.
Yeah, why not? I mean, if you think, if you feel confident.
And if patient understands the repeat TLR procedure and doesn't have a problem in doing it, and patient is wanting to get a PCI done alone, for the sake of 20% people who reach to nose, all the 100% need not be subjected to surgery. That argument can be, do you take that? 80% of the patients will do all right with PCI. So you can do it. If patient wants it, Digvijay sir has introduced one term. So that's why I get a little perplexed. So on-demand surgery, he said. So on-demand PCI. So if patient wants PCI, would you do it at 70 years?
No, in fact, you'll find more people with on-demand PCI compared to on-demand surgery, correct?
Honestly, sir, about 30% of my procedures, patients are told outside surgery, they come with a CD saying that, sir, you tackle without surgery, I believe, please do my procedure. For money is no problem. Stent number, no problem. I am okay with the repeat procedure. So I keep explaining them repeatedly that one stent fails. You shouldn't be saying that stent has failed and all that, but still they will take undertaking and then we do procedures. Average stents now per patient is 3.54 per patient.
And so some of your waiting list patients, you can send them to us in Pune.
No, we are not that busy, sir. But what I'm saying is, compared to what it was before, where we are using one stent per patient, because stent prices were high. Now stent prices being, in spite of using 3-4 stents, you are still cheaper than surgery.
And not only that, Srinivas, what our practice is and what we are seeing is, as the patient's age advances, the bystanders always prefers a non-surgical procedure, intervention rather than surgery. And nowadays, many people, especially youngsters, when they have complex disease and somebody says surgery, they immediately leave that place and comes to another center and asks, can an angioplasty be done? As you said, I don't mind whether the reprocedure is there or not. Why don't we take a chance, sir? We'll do an angioplasty, and if the angioplasty fails, then we may think about surgery.
Yes. Many times questions come like this.
Javier, I would feel you see a CD and you should ask yourself that question. If that was your angio, what would you want to do? and how old you are. And I think that gives the correct answer to all of us.
Fully
as
agree.
to whether he should go for surgery or whether he should go for angioplasty.
But then many people have personal preferences. Some of them are, look, you manage me medically. I don't want to go for surgery at all.
Though I think many people have moved away from this, they are told this angio CD is not for medical treatment. I think that is the first statement one would make when they come to you or I. And then we talk of two options, whether it's angioplasty or surgery. People would probably still feel that they would want an angioplasty because it's simpler, like just 2-3 days and they can be back at work. And
we have surgeon with us, sir. So suppose we're not wanting it to happen, but suppose as sir said, if you put in that position, would you like to cut chest and get all the things done, or just by a small radial procedure get a PCI done?
No, sir, here I agree that PCI has come for a reason, and that reason has to be respected.
Thank you.
Don't change with times, you are outdated. So yes, most of the time endovascular surgery is indicated where in a skillful hands will give you better results. The biggest advantage I see is in the thoracic aneurysms that used to operate first. Now we are doing all TAVIs. Why? Because the results are distinctly superior. Similarly for coronaries, like Heramat sir is very clear. Like I would personally rather have 3 angioplasties in my life than 1 angioplasty and 1 bypass. That's the end of the story.
Wow, that's a very
Thank
good
you.
meaning at the end.
We should close on this happy note now, sir.
Yes,
Close on
at
this
the end
happy
of
note.
2 hours. I think if that is a statement from you, Dr. Digvijay, I think we are all very happy about it.
Yeah.
Thanks for joining, Digvijay sir. We also learned a lot of things from you today. Thank you.
Absolutely. I think it was a very, very interesting therapy that you showed us. I mean, we've been doing it. We used to do it, rather. Let's say we used to do it, but we stopped last 10 years. I don't think we are doing anything like
it takes too much time, sir. We can do a lot much more work. I left it to other juniors because it's a lot of time consuming, a lot of radiation. So I left peripherals to my other colleague. So same thing, because we need to show them work also. Otherwise, juniors won't, they have to stay with you in the group also. So we have definite compartmentalization now. I make them happy and let them also develop in that field so that our team expands. And patient gets the best, sir, that way.
Exactly.
Yeah, I think that is very important. The patient gets the best. Like if you pass it to a junior, and if you're around, like if you're doing something else in another cath lab, you can keep coming and keep talking to them, and that's how this junior also will give you as good a result as you will get. So I think that is very good for the patient.
Yes.
Dr. Neha and Dr. Omkar, we have been chatting for last 2 hours.
Yes.
So maybe we should close at this stage. Dr. Jabir, what do you think? We close?
We may close, but it was quite interesting discussion. A lot of things we have learned from experience, the consensus, the way difficult people should be managed. And it's not only medicine, some philosophy also, which you have accrued over years.
And I really like interacting with Hiramat sir, honestly. I'm not telling in front of him, because he really talks what he really does and what he feels. Unlike many of other colleagues who say something and do something that is of no good. So that we can tell a lot of good things also. And if you don't practice really, then it's waste. So what he really does and what he really feels from heart, you should talk. I also feel the same. I respect him a lot for that. And thank you again, because we exceed time sometimes, Omkar and Neha, because of this reason. So a lot of procedure thing we can learn, but some things, a philosophy behind it, what sir keeps telling, that all of us youngsters should learn, because many of the youngsters think it is only angioplasty, putting stent and dilating. That is not the thing alone. A lot of science, philosophy behind also has to be learned, and patients' interest have to be kept on top priority.
And most important thing, he is not quoting this data. He always tells, this is what way I have been practicing, and this is because of this particular fact that I was practicing like this, not data.
That gives a lot of confidence to us.
I just feel that I'm spoiling my postgraduates. by teaching them that all can be done with angioplasty.
Right.
But I think, sir, you have this is a lighter way I'm telling, sir. Don't take it seriously, Digvijay, sir. If you have a bad surgeon with us, no, you have very good experience in graft interventions. I have never seen a person who has more experience with graft interventions than Hirabat, sir. We had one hospital, I don't want to quote the name here. Whenever you put a graft to Lima to LAD, it used to stenosis, anastomotic site restenosis block. That cardiologist there has developed maximum experience in Lima to LAD anastomotic site PCI technique. So sometimes the bad things are also blessings for us to think through the technique.
We can enhance our skill.
The other thing is, there are some centers where the surgery has not grown along with cardiology. Surgery is lagging, and cardiologists are pushing percutaneous intervention extra.
No, surgery is no joke, sir. The same things done in Apollo Hospital cannot be done in a smaller hospital. Let me tell you, that is very important.
No.
Surgery is a lot dependent on operator, more dependent on operator than the PCI procedure. So it's very important.
Our surgeon is damn good. That is a major problem. I think we should go for a surgeon.
Look at the way Jabir is saying. That is the major problem he's saying.
In our place, sir, to develop TAVR in our program, we have 4 surgeons. 2 are cooperating quite well, and 2 operate on sick patients. They become all right. Extremely talented surgeons. But let me tell you, unless any surgeon or a cardiologist, if you don't go with what is the data coming, what is good for the patient in the long run, you'll be left behind. So what is good for the patient has to be practiced by anyone, be it be surgeon or be it be interventional cardiologist. No, otherwise, you'll be left.
No, Dr. Srinivas, I would feel that, decision is angioplasty. 40% of us will say yes, angioplasty. Decision is bypass surgery. 40% would say yes, bypass surgery. But there are another 20%, and you add age to that.
Yes.
Age, I think, is a very important factor. So when you want to take somebody from age 50 to age 90, and people are really, really expecting. One of my patient at age 94, I told him that you have too many blockages and I can't do angioplasty on you. So he said, why not surgery? And he underwent surgery and he moved from 94 to 101. Okay. While his wife was about 89 when all the problems started. Poor thing died when she was about 4 years from that time. So, yes, I think a lot depends. I mean, we are all moving forwards. I think Dr. Neha and Dr. Omkar would be very happy to see that we are all thinking together and we all want to give very good longevity to the patient. They live well, they live long, they enjoy life, they earn money. And that is how I think...
you also give good business to Emcure.
We just talked about a supermarket concept. I don't think so that holds true anymore. I think we all are talking on a very humane ground for the last 1 hour. So that's very heartening. And particularly, sir, since the last episode, I believe, apart from the usual discussions we do, most of our discussions are centered around patient-centric, which we say, raising our EQ as well. And which is
that is where the smartness lies. You see 2 cardiologists, one does extremely well and the other one equal level, and technically he would be equal, but he's not doing that well because the first one is thinking for the patient all the time. Same with surgeon, and that is how I would feel. Technique is probably same, but its application to a patient, that is where the difference comes. And that's why some people do very well, some people may not do very well.
Absolutely. Absolutely.
So I think we had a very enjoyable evening. Dr. Digvijay, we clearly went beyond the time allotted to us because of your presence, though your presentation was very short to the point, but then we have had lots of arguments, so to say, some for and some against surgery, some for and some against PCI. But that is how life goes on. I think those of us who are practicing angioplasty for 30 years and more, we have seen the huge changes which have taken place in angioplasty. What we used to ourselves send to surgeon, we don't send it anymore because we have started adding age to that factor. So when a 40-year-old presents with multivessel disease and an 80-year presents with a multivessel disease, our approach clearly changed. And we must all thank Emcure, Dr. Omkar, Dr. Neha, and all your colleagues. Thank you indeed for bringing us all together. And we really enjoy and look forward to this meeting, which comes every 15 days, right? Right. So,
Thank you, sir.
Dr. Digvijay, you can join us in whichever capacity in future also. Same invitation to Dr. Jaina and Dr. Guru.
Thank you, sir.
Thank you.
Thank you, sir. Thank you very much.
Okay,
We
sir.
will be catching after 15 days on 23rd of December with the same enthusiasm with 3 more cases. Till then, have a nice time. Good evening and good night.
Good night.
Good night. Good night.